Okay, this is a great case. This is a 66-year-old gentleman who's had pain at the midfoot and the tarsal region. And the question was, is this inflammatory arthritis or what's the etiology of this? And when we're looking at this case, what we can appreciate that the field of view is very large. And I would suggest that if you're doing foot and ankle imaging, you want to include the hindfoot to the level of the midfoot for any ankle protocol or hindfoot protocol. And then the forefoot would include the midfoot. So you can start at the middle of the cuneiforms and look out to the forefoot. And if it's a specific issue with the plantar plates, you may want to do a toe protocol in addition for diabetic foot. But looking at what we've got here is we have some kind of edema in the lateral cuneiform and in the cuboid, and I want to try and look at that in a coronal view so that I can understand what's going on. And when I look at the talus to the calcaneus and come into my navicular cuboid and then pass to my cuneiforms, I'm getting to this area where there is some slight edema in between the lateral cuneiform and the cuboid. And what I can appreciate is that there's an intermetatarsal ligament. There's some mild sprains in this region that we can appreciate at the Roman arch of the midfoot. And because of the proximity and the arrangement of these bones, we can see that there may even be some more stress response between the base of the third and the fourth, that there's a close proximity. But what I'm seeing is this stress response. So let's take a look at T1 weighted images and notice I'm seeing some kind of T1 change. So this is not just a brand new contusion. This has had some time to form some degree of calcium response or sclerosis. And what I'm interested in understanding is what is the biomechanic that might be responsible for this? The question is this inflammatory arthritis? And one thing that I can't answer that alone on an MRI. I would want to run parameters that check whether or not rheumatologic profiles, what we call it, to understand what is the etiology of my effusions. But I'm also going to try to understand, can there be a biomechanical reason for that particular finding? So what I'm seeing here is between the cuboid and the lateral cuneiform, there is that stress-related edema. And I would say that looking at the Roman arch of the midfoot, we can appreciate that there is some kind of osteophytes and degenerative change, and there's a subtle gapping in between the base of the fourth and fifth. So as the fifth goes out, which is making a bunionette deformity, we can appreciate that there is some kind of mismatch between the cuboid and the lateral cuneiform, and indeed there's interligament sprains in this region. We talked a little bit about why that might be the case. So sometimes when you have pes cavus and an elevated arch, there's something that can be seen on the x-ray, something what's called a metatarsal stacking angle. And when the metatarsals are stacked up high, as we move from the hind foot heel strike towards the forefoot, it can be a difficult biomechanic to smoothly roll through. And as the bones become degenerated, we can have different interligamentous sprains, or perhaps there was a marathon running or we did some kind of exaggerated performance sport that caused that. But even in the absence of that, when we have patients who have neuropathy, they begin to have intrinsic muscle weakness, and that can affect the gait and certainly affect your heel strike. So that would be another thing that I would be checking to see whether or not we have that. I don't see any large erosions or anything that I would think that there's underlying inflammatory arthritis. And when I'm looking at the additional regions of the plantar heel spur and looking at our retrocalcaneal bursa, those are not distended regions in this particular patient. So I think biomechanical reasons are the cause of what I'm seeing here. I would like to go back into my hindfoot now, and because it's a wide field of view, it's kind of difficult to see, but I think you can appreciate the extra articular anteromedial talocalcaneal coalition and this exaggerated facet that's locking this region. And so there's an anatomic predisposition to altered biomechanics here, which may create the situation as in rear foot varus, where the patient has exaggerated heel striking and then uncompensated biomechanic to get to toe off. Let's just take a look at the forefoot and understand that this patient, if they're coming in on their outer side of their foot in a supinated mechanic, they have to get all the way over to the great toe in order to toe off. So we're looking at the forefoot parabola to understand at what phase of the biomechanic are they in. So what I'm seeing here is a subtle reversal of the forefoot parabola. And let's take a look at that now on T2 weighted images, where we can appreciate the plantar capsular thickening even at the second metatarsal. This is a low-grade partial tear of the plantar plate on the fibular side at the proximal phalangeal attachment. We can see some trace intermetatarsal bursitis at the second and third spaces. Let's take a look back on T1 so we can understand, do we have a pseudoneuroma or perineural fibrosis in this region? And there is some minimal perineural fibrosis, but If it's not cross-sectionally 3 millimeter, I usually am not going to call it just the same as a neuroma, but we can appreciate some of those changes here, that there is some degree of perineural fibrosis that's hugging the second MTP. Now let's look at the second. We see that there may even be a subtle hammer toe deformity, and let's just get over to the first. So this is the second. So there's a subtle hammer toe deformity, and even in fact, we can appreciate that it may be moving towards a situation where it wants to do a medial crossover of the second to the first toe. So putting it all together, what I'm seeing is an extra-articular anteromedial talocalcaneal fibrous coalition, and I'm seeing a sprain between the cuboid and the lateral cuneiform with stress-related edema. I'm seeing some degree of atrophy along the deepest layer of the muscles of the foot, and I'm seeing second plantar plate low-grade partial tear, fibular side, distal phalangeal attachment. Thank you.